Okay, here we go. Chapter 59. I'm going to turn my picture off. And share screen. I downloaded a lot faster without my picture. I'm glad. So this is about problems with the biliary system in the pancreas. It's a nice little review of the GI tract. Again, I've mentioned before, you have the videos. Okay, let's talk about gallstones. There's acute, and then there's chronic. So acute can occur in the calculus and acalculous cholecystitis. That's the most common type is the calculus cholecystitis, which is a chemical irritation and inflammation resulting from gallstones, cholelithiasis, which we're going to do. A chronic cholecystitis results when repeated episodes of the cystic duct obstruction cause chronic inflammation. Calculi are almost present. In chronic, though, the gallbladder becomes fibrotic and contracted, and it results in decreased motility. Let's talk about the gallbladder. It sits under the right liver, and the right side primary function is to store and concentrate bile produced by the liver, ready to deliver if needed in fat digestion. So gallbladder comes in real practical during the holidays when we are eating a lot. A cholecystitis, that is the inflammation of the gallbladder wall. It's commonly caused by gallstones obstructing the cystic or common ducts. Bile flows from the gallbladder to the duodenum or duodenum, however you want to say it, and it causes bile to back up and the gallbladder to become inflamed. A calculus cholecystitis is without stones. Cholelithiasis is the presence of stones in the gallbladder, and it's related to precipitation of either the bile or the cholesterol in stones. Bile is used for the digestion of fats, like if they eat something, eat a whole cake, or I don't know, think of fatty things you may seen people eat. It's produced in the liver. I'm sorry. Bile is used for digestion of fats. It is produced in the liver and stored in the gallbladder. It can be like acute or chronic and can obstruct the pancreatic duct, causing pancreatitis. It can also cause the gallbladder to rupture, which is a secondary, resulting in peritonitis. So that happens on top of that. Risk factors, more common in women. Hormone therapy and use of some oral contraceptives, high-fat diet, obesity, so there's some genetic component, diabetes type 2, Crohn's, low calorie, a liquid protein diet, and rapid weight loss. What are the signs and symptoms? And I told you about acute and chronic difference. I said that earlier. Okay, signs and symptoms. Sharp right upper quadrant pain radiating to the right shoulder. Murphy sign is deep with inspiration and during the right subcostal palpations. So pain with deep inspiration in the right subcostal. Lummer, B-L-U-M-B-E-R sign is rebound tenderness, and that is only performed by an MD or an advanced practice. I've never seen a Lummer sign. I've seen the Murphy sign. Fever, some other signs such as fever, gas, steatorrhea, I think that's fatty stools, pruritus, nausea, vomiting, and after ingesting a high-fat diet. Jaundice happens with obstruction of excess bile salts accumulating under the skin, and that causes itching, which is pruritus. Chronic cholecystitis leads to dark urine and funny clay-colored stool. What are the labs? A white blood count, an AST, an ALT, an LDH. These all get increased, and it's quite common in bile duct obstruction. Total bilirubin increased if the bile duct is obstruction. Amylase and lipase if the pancreas is now involved. Okay, diagnosis, how do we do it? Ultrasound, X-ray, CT, ERCP, MRI. The meds we would treat would be analgesics, opioids, NSAIDs. But that NSAIDs mess with the liver. All right, bile acid, chenodiol, uracil gradually dissolves cholesterol-based gallstones. Let's see. Other treatment, yeah, there's a lithotripsy. That before we get to the cholecystectomy, which is the removal, you could do a lithotripsy, and it's shock waves used to break up the stones. But a cholecystectomy obviously is the removal. There's two ways to do that: laparoscopic, which is minimal invasive or open. They can go through the mouth, vagina, or rectum to decrease risk of complications. If they do a traditional open, sometimes they have a Jackson Pratt, often called a JP drain, to accumulate the fluid in the, yeah. Okay. NPO, obviously, nutrition therapy. I mentioned the J-tube, opioid treatment, a PCA pump so the patient's pain is controlled. What do we want to do nursing-wise? Low-fat diet, record the output, watch the color and consistency. I'm sorry, post-operatively. Jumping all over the place. Record the output as directed, watch the color, report any changes, and if the patient's in severe pain. But hopefully the PCA pump will help. And look at the wound if it's open. Nursing care, monitor incision sites, like I just said, empty the drains, promote weight reduction. If they do this laparoscopically, they cannot eat until they pass gas. So those are the fun things we ask as nurses. You don't say, do you have flatus? Are you passing gas? Because we want to make sure they don't have a paralytic ileus. That's bad. Complications, the surgery could obstruct the bile duct. It can cause ischemia because being cut off, gangrene, rupture of gallbladder, abscesses. I talked about peritonitis. That's then all this happens with surgery and of course antibiotics. Another one is bile peritonitis. Adequate amounts of bile are not drained from the surgical site. That can be potentially fatal. So we need to monitor vital signs, which is fever and pain, and look for signs of jaundice. Cancer of the gallbladder. I don't know why they say poor prognosis, probably because there's so many other organs nearby. These are severe gastric right upper quadrant pain. If it's caught early enough, I'd say. So that's a little kind of quick summary of the gallbladder. My niece had hers out, and she was really young. She was like 20 at the time. So it's not necessarily age. Pancreatitis. We have acute and chronic. Acute pancreatitis is the inflammatory process, and it's due to activated pancreatic enzymes auto-digesting the pancreas, ranging from mild to necrotizing, the unscathed necrotizing. Hemorrhage, pancreatitis, widespread bleeding, and necrosis. Let's talk about acute for a second. It's sudden inflammation. It's caused by destruction by own digestive enzyme, autodigestive, and it is reversible. Risk factors are gallstones, obstructions, alcohol, trauma, cystic fibrosis. Sudden epigastric pain is the signs and symptoms. May radiate to the back, may radiate to the left flank. Some bruising or ecchymosis on the flanks, that is called Turner's sign. So what I would do is start writing down these signs, the Bernie's, Murphy's, Turner's. It's worse when they lie down. They have pain after eating. There's a vitamin deficiency, hyperglycemia, warm, moist. So hyperglycemia is somebody's warm, moist skin and fruity breath. Tetany due to hypoglycemia. Now that is called, then also look up Trousseau's and Schoptic sign. There's a nice picture of acute pancreatitis. Diagnosis on acute would be elevated lipase, amylase, white blood count, ASATs, ALTs, glucose, remember acid rate, decreased platelets, calcium, and magnesium. So acute and chronic have the same pretty much meds and treatments. I'll get back when we get to chronic. So this is a kind of fun slide. It kind of shows what goes on. It's an interesting pathway. So you get the obstruction, you can get direct injury, or it can produce the release of pancreatic enzymes. So take a look at this and kind of follow it through. Complications of acute: hypovolemia, hemorrhaging the kidneys, paralyzing ileus, shock. They also can get pleural effusion, respiratory distress, start shutting down all the organs. Sounds scary, doesn't it? Disseminates coagulation, and then I mentioned earlier too, the diabetes. Chronic is persistent inflammation, and it's caused by changes in structure, fibrosis, atrophy, calcifications. Chronic is irreversible. Acute is reversible, chronic is not. Risk factors for this. Let's see. Repeated bouts of acute pancreatitis ends up leading to chronic. Healthy tissues replaced by misshaped ducts, fibrosis, calcium deposit. Nausea, vomiting, scientific jaundice, ascites, absent bowel sounds, left shoulder pain. There's something called Cullen sign, a bluish gray peri-umbilical discoloration. It's relieved when they're in the fetal position. Food and fat malabsorption, and steatorrhea, fatty stools. So picture chronic. This is the serious one. If you get an abscess in there, remember things are now totally shutting down, so you're doing blood cultures. They would definitely want to do some type of a scope to get in there and try to remove the abscess. And the antibiotic treatment, of course. Pseudocysts, sometimes pancreases get these pseudonees fade. They can cause hemorrhaging, they can become an infection, they can do all these things listed below. It may resolve. Sometimes docs want to monitor it. If it doesn't, then they do want to do surgery. Pancreatic carcinoma, who's the guy that does Jeopardy? Doesn't he have pancreatic? depending on, again, we talked about stages of cancer. So you definitely want to non-surgically, some type of therapy, radiation therapy. They even try to put a stent in. And there's a nice picture of pancreatic cancer. So we'll talk about the Whipple here in a minute. Preoperatively, the NG tube, TPN, and TPN is in chapter 60, so we'll talk a little about that later. Post-op, obviously, observe for complications, frequent vital signs, positioning, fluid and electrolyte, and glucose monitoring. A Whipple. What is a Whipple? I'm taking care of a few of these. All right, bear with me as I read these long words. It's a radical pancreatic duodectomy. It removes the proximal pancreas adjoining to the duodenum and distal portion of the stomach. The distal portion of the common bile duct. It's quite an invasive procedure. The pancreatic bile ducts and stomach are reastomosed to the jejunum. And that picture kind of says it better than the picture visualizes it better than I said it. Yeah, there we go. All right, I'm going to stop the share. So the main thing with this chapter is know the disease, know the signs and symptoms, know the medications, and what your job as a nurse in assessing pre-op, post-op, and just in general.